Our patient diagnoses for this case study were subclinical hypothyroidism affecting fertility, preconception counseling, and history of bacterial vaginosis. As we have recently learned, various opinions exist about treating subclinical hypothyroidism. Therefore, we have divided our research into those in favor of treatment, against treatment, and finally the research weighing the benefits versus the risks of treating. The research in favor of treatment states, preconception counseling for overt hypothyroidism should follow the normal treatment regimen. Additionally, because our patient with subclinical hypothyroidism had plans to become pregnant, she should be advised of the increased metabolic need of TSH during pregnancy and should come to an appointment at first signs of pregnancy in order to increase levothyroxine dosage. In 2014, Liu et al. Used a prospective cohort study of 3,315 women to compare thyroid dysfunction and miscarriage. Women with subclinical hypothyroidism and isolated thyroid autoimmunity were found to be at an increased risk for miscarriage between 4 to 8 weeks. Consistent with these findings, Yim reports in the Journal of Endocrinology and Metabolism, while American Thyroid Association guidelines recommend the treatment of pregnant women who have subclinical hypothyroidism and positive TPO antibodies, the guidelines of the Endocrine Society and the ETA recommend LT4 treatment for all pregnant women with subclinical hypothyroidism, irrespective of their TPO antibodies. The 2017 guidelines by the American Thyroid Association state that the infertile women with subclinical hypothyroidism that were prescribed LT4 therapy had better chances of successfully conceiving. Alexander et al. Conversely, other research states that thyroid hormone doesn't help to improve outcomes, and ACOG stated in 2015 that subclinical hypothyroidism should not be treated. In 2012, Widsack et al. Conducted an observational study of women with diagnosed hypothyroid and concluded that the majority of the women did not achieve the preconception or early gestational goal of TSH less than 2.5 milliunits per liter. But they were also not associated with adverse fetal or maternal outcomes. Other research maintains that the benefits of treatment outweigh the risks of non-treatment. The Endocrine Society's 2012 guidelines caution prenatal providers to avoid overt maternal hypothyroidism due to association of serious adverse fetal side effects, de Groot et al. Adjustments should be incremented every 4 to 6 weeks based on the half-life of T4. It's important to remember that pregnant women may require a 30% increase in T4 dosage. Alexander et al. 2017 conclude, despite imperfect data, the majority of evidence appears to support an association between overt thyroid dysfunction and an increased risk of infertility. Thyroid dysfunction is also reversible, and treatment is generally safe and may exert a positive effect on fertility. Therefore, it is reasonable to treat overt thyroid dysfunction in infertile women with the goal of normalizing thyroid function. One special consideration for pregnant patients is iodine supplementation. Pregnant women should be receiving 250 micrograms a day compared to the 150 micrograms recommended by non-pregnant individuals. So given the research, how was our patient managed? Our patient was managed by thorough analysis of current evidence and guidelines, followed by the weighing of risks to benefits in treatment versus non-treatment. When current literature is conflicting, it can be a difficult decision for providers to choose to treat or not to treat. Our management included treatment of our patient's subclinical thyroid dysfunction in order to improve fertility outcomes. The evidence above was used to formulate our clinical plan. The patient was presented with the current evidence and guidelines in regard to treatment of thyroid dysfunction versus non-treatment, and the patient chose treatment. Why? Treatment of hypothyroidism in preconception is evidence-based and associated with possible positive effects on fertility. The management of our patient was safe. The choice to treat subclinical hypothyroidism especially eliminates any complications that may present themselves when not treating in a preconception period, like risk of infertility. On the other hand, there are no unsafe side effects to the fetus associated with non-treatment, so either choice for the patient would have been acceptable and safe from our perspective. Additional considerations should be made for careful observation once therapy is initiated to prevent overtreatment and subsequent hyperthyroidism. The treatment of the patient was indeed thorough. Her current health status was addressed, and a plan for the future that would increase her chances of conceiving was made. For example, prenatal vitamins, birth control to regulate her period, education on ovulation testing, and fertility. She was also given education and information on BV. Improvements could have been made by giving her natural options for BV treatment like probiotics or boric acid. The care for the patient was patient-centered as she helped to determine her own plan of care. She was given evidence in regard to thyroid dysfunction and was given the choice to treat or not. She was also given education on conception, fertility, and BV, which is patient-centered and individualized in nature. Positive health behaviors in regard to BV were taught in order to avoid recurrence of this vaginal infection. Additionally, the patient was encouraged to take her health and fertility into her own hands by using ovulation tests and given information on fertility. This is a self-empowering health behavior. In conclusion, the take-home points for our case study are: counsel patients thoroughly on the importance of comprehensive preconception care to identify needs early. Thoroughly assess for patient history, family history, and current signs and symptoms of hypothyroidism, especially during childbearing years and if conception is desired. If there are risk factors or concerns, draw an early TSH. If this level is greater than 4, start Synthroid based on the patient's weight and recheck the level in 4 to 6 weeks. If the level is 4.0 or greater, draw TPO antibodies. Generally, assays change, so one easy rule of thumb is to subtract 0.5 from the maximum range of the assay used by an institution. During pregnancy, the TSH should not be greater than the number calculated. Also, when caring for pregnant patients, the TSH levels should be checked each trimester if the patient has been previously diagnosed or found to have hypothyroidism. The TSH should be maintained below 4.0. Initial treatment for pregnant patients should be Synthroid 2.0 micrograms per kilogram per day, PO in the morning. Patients should be educated to separate their Synthroid dose from meals and take it 1 hour prior to breakfast and other medication. They should be instructed not to take Synthroid with calcium. Prenatal vitamins, ionized salt or iodine supplementation, and omega-3 fatty acids should be consumed. Finally, Armour is not a substitute for Synthroid due to the differing T3 to T4 ratio and is actually contraindicated in pregnancy. And that's our case study. Thank you for listening.